A very good morning. I warmly welcome you for the SARC Symposium and of challenges of surgical practice during changing scenarios of COVID-19 COVID-19 pandemic. I think there are a number of speakers, so I think we will move on to the first speaker, my friend, our friend, Professor Maudud Hussain Alamgir.
Mr. Chairman, very good morning to everybody. This is a great opportunity on my part to be present here as a speaker on this important session on the SARC, where we have just discussing about the challenges that we have faced in the change scenario of the COVID, especially those who are working as surgeons. Now, let's start sharing my screen. This COVID, in fact, has come up with a great challenge for the surgical practice. The changing scenario, as we can all appreciate, this was something new for all of us, and the scenario that we have faced was a little different. Actually, if we start with the country statistic, as on 25th November 2020, the total number of infected patients so far in our country was about 1.6 million, and the total death was 27,970. And unfortunately, the number of deaths was also among the surgeons in a good number, which was about 130. And special mention about the death among the surgeons, which is alarming me, about 27. And especially, I just want to mention one name, Professor T.M.A. Farooq, who was a founder member of the Surgical Care Society, and unfortunately, we have lost him during this COVID period. Actually, if we just see back to those days, it was a black days, in fact, and still we are not out of that. It was a sudden blow to the surgical fraternity as a whole, all over the world. And we felt that we are really isolated from the rest of the world. And the situation was very unfamiliar because we were not used to this type of situation before. We have seen so many pandemics in the history, but which this time, this is absolutely exceptional and has ended up almost the entire globe in a very short period of time. We faced so many new terminologies, lockdown, shutdowns, and we have also understood and felt how a life can be stopped totally by a small, tiny virus, which can take us to that limitations. And this has definitely restricted the hospital services. And if we just go back to those black and the gray areas of those days, that we have lost so many eminent surgeons of our country. Many and thousands of the surgeons were affected. And there was a feeling of helplessness. Actually, we didn't know what to do with. And there was a lot of waiting patients who had cancer, and also patients attending with the surgical emergencies and traumas. But we really felt very helpless during that time because we didn't know really how to deal with this and how to protect ourselves from that virus. And whatever the protective gear we had in the initial days, which was proved to be very limited, and we didn't have the proper and ideal protective gears at the beginning. And our theatre standards was really questionable to deal with COVID patients on those days. And just forming the surgical teams with the members who were willing to participate was really a challenge. And there was also another challenge, the selection of the patient. Who were the patients to be taken to the theatre was another issue that we had to deal with. And there was another serious issues because there were so many waiting patients who had their follow-up scheduled, but we couldn't afford them to take them to the hospitals. And the uncertain waiting list, which was just beginning long and long as the days passed. And though we have introduced and started the online services, but this proved to be very limited, as we all know that this has got really limited values in surgical practice. And there was another challenge of dealing with the COVID and non-COVID patients simultaneously. And for many situations, both patients and the surgeons and the doctors had to avoid the hospital visits and hospital admissions. But the few things came into practice on this day because the infective situation was such that the infection prevention of the control guidelines was another important issue that was seriously talked on those days. And the issues of creating negative pressure theater and was a very important issue. We have all discussed about that, and the need of those was also felt and realized once again. And the concept of the HEPA filter was also in practice, and also this was discussed a lot. But there are other side of the card. Everybody will talk about the bad effects of the COVID and the challenges and the destruction that it has caused. But I just want to talk about the other side of the card. There are a few benefits that we have achieved out of this COVID. Actually, we didn't have any vivid idea about the word triage. This was the textbook word mostly, but this COVID has proved that it has got some reality. That's why we just separated our patient infected with COVID in red zones, suspected one in the yellow zone, and the clear patient in the green zone. And the real life advantage of practicing triage was proved once again. And definitely we also learned how to avoid the zone contamination, how to be specifically concerned and confined with a particular zone. And this altogether, we just felt and realized that this gives a very good results in practice and offering services to the patient. The another issue was the WHO safety guideline, which was not seriously practiced in many centers before the COVID, but we have felt that during this period, most of the surgeons were strictly adherent to this WHO safety guideline. And its practical application was becoming popular more and more. And number of the users of this guideline increased every day. And definitely there were different results and the benefits was proven. And this COVID period, we have realized that the number of the infections and morbidity and mortality has reduced tremendously during this COVID period, despite we had a lot of limitations. But the most notable thing that I want to mention about the benefits, that is the surgeon-patient relationship has improved. Due to many reasons, this was compromised before. This was at stake, but there was sudden improvement because patients came to understand that doctors have sacrificed a lot during this COVID period. They have taken care of the patients, endangering their own life. And this has improved the trust and the confidence between the patients that their surgeons are really their friends. So the reality is that we have to live with COVID. This is not over. And we believe in the coming days, definitely we'll meet personally in physical appearance will be there and we'll meet our friends again. Thank you very much. And thank you for giving me this opportunity to present this on this occasion. Thank you very much, everybody.
Thank you, Professor Alamgir, for that real-life account of the dark period we all experienced and the challenges and your response to it.
Our next speaker is Dr. Tashi Tenzin from Bhutan. He's a consultant general surgeon and a neurosurgeon. He's a vice president of the Association of Surgeons of Bhutan. He's an active member in SARC Surgical Care Society, and thank you very much, Tashi, for joining with us. Over to you, Tashi.
Good morning to all our SARC surgical friends. Greetings from Bhutan. I'm Tashi Tenzin, representing Surgeons of Bhutan. At the outset, I would like to thank the organizers for inviting Bhutan to participate in this very important Congress organized by College of Surgeons of Sri Lanka. I also like to thank all our great leaders of SARC Surgical Society for bringing us together on this forum, although virtual. I'll be happy to share situation of COVID in Bhutan and also how Bhutan responded and how COVID affected our health services and how we managed. I may put off my video from here so that there's no disturbance. Bhutan was cautious enough that nationwide preparedness started 2 months even before the WHO declared the COVID-19 as pandemic. But Bhutan had our first case on the 5th of March 2020. Subsequently after that, contact tracing, testing, and treating of the positive cases were done. As the numbers gradually increased, Bhutan had to observe 2 nationwide lockdowns. Although our cases were mostly imported by Bhutanese returning from home, returning from other countries, and incoming international expats. We also had local transmission in some of the districts, but the lockdown had helped this to be controlled successfully. Bhutan had our first COVID vaccination on 27th March 2021, and so far over 80% of population has been vaccinated. To report on the status of the numbers, as of 19 November 2021, we have 2,632 confirmed cases, over 2,619 cases recovered, which comes to over 99% recovery rate. We have, as of now, 10 active cases, and so far only 3 deaths. Bhutan's response is very unique in the sense that His Majesty the King of Bhutan led the fight against this pandemic. His dynamic and compassionate leadership guided the health professional-led government, which is responsible for successfully managing the pandemic. Bhutan's government at this juncture is led by health professionals, like Prime Minister is a surgeon, pediatrician leading the Foreign Ministry, and the Health Minister led by the public health specialists. Bhutan followed 21 days quarantine. However, quarantine services were totally provided free by the government. Government also identified hospitals for COVID-19 positive cases for treatment as well as for the isolation. Bhutan followed some of the internationally accepted management guidelines. In response to the essential health services, immediately we established flu clinics, toll-free numbers for any assistance. Medical mobile units were established and deployed. Senior citizen services were established, and also teleconsultation through mobile were provided, and even prescriptions were provided so that they can collect their medications through mobile medical units. We also followed a temporary distancing method whereby 3 teams were formed, one in the indoor department, other one in the outpatient, and the third one is staying home, where teleconsultations were provided by this, so that no team gets affected at all, so that somebody is always there to take care of the hospitals. We have to also recall all the doctors undergoing studies abroad. Challenges in the surgical services because of the restriction of the movement within the districts, and also sudden lockdown, disruption of the movement and activities were seriously affected. However, medical teams, including surgeons, were deployed in the affected and identified hospitals so that surgical services were not affected. We also followed international standards like emergency services, cancer surgeries, and some selected surgical cases were given preference. Bhutan also, the teams have developed the COVID positive surgical guideline. Interestingly, not a single COVID-19 positive case had to undergo any surgery as of now. Unique to Bhutan is referral to India for specialized care. For example, neurointerventions, digital subtraction angiographies, and many more. These were affected because of the restriction of the air travel as well as the ground travels. However, some selected cases had to be evacuated through special arrangements. So, although Bhutan did not really experience in the surgical management of COVID-19 cases, but we are still vigilant that you never know when the positive case will come. So we are very, very vigilant on this, and we'll follow whatever international standards in the management of surgical COVID-19 positive cases. So with this, I'd like to thank once again for giving us opportunity, and we wish all a very enjoyable Congress, and hopefully we will be able to pull through this pandemic as soon as possible so that we can personally meet each other very soon. With this, thank you so much.
Thank you very much, Tasi, for that excellent presentation. Actually, if the pandemic was not there, we would like everyone of the SARC Surgical Care Society representatives be here in this our Golden Jubilee Congress. So let me hand over to Dr. Pinto to introduce next speaker.
Our next speaker is Professor Muhammad Farooq Afzal from Pakistan. He is the president of the Association of Surgeons of Pakistan in Lahore chapter. Currently, he is attending our conference, and as Bhavanta mentioned, all the speakers are the members of this SARC family, isn't it? Yeah. Over to you, Professor Afzal.
All right, thank you very much for giving me the opportunity. I'm going to talk about surgery in COVID pandemic in the next 7 minutes. And I'm going to share experience of two hospitals, ones who completely followed the COVID protocols and another one which did not. And the goal of this presentation is to describe our experience of both elective and emergencies and surgery during the COVID pandemic of the last 1.5 years. So COVID-19 is a disease caused by SARS-CoV-2 RNA virus, which has a highly infectivity rate and ability to mutate, and that makes it very vulnerable to not only to spread, but also difficult to develop vaccines against. COVID pandemic started in Wuhan, China, in December of 19, and then since March 2020, it's spread like a wildfire through the whole world. More than 80 million people are already infected, and almost 1.7 million deaths has already occurred worldwide. In Pakistan, we have more than 28,000 deaths the last 1.5 years, and we just recently had our 4th wave completed. Since the development of vaccines in the early years, in January 2021, we have seen the dramatic decrease in mortality, and up till November 21, we had 49 million people in Pakistan vaccinated, which is about 23% of our population. And worldwide, 7.6 billion doses of vaccines already been administered. Unfortunately, we lost many high-profile surgeons, including vice chancellors and very eminent doctors and surgeons during the whole process. Surgery was a great challenge, and the reason is, number one, the risk of getting infection. And since we didn't know about that infection recently, and still not a complete knowledge is available. So because of that, people were reluctant to come and see the patients. Secondly was the availability of proper personal protective equipment, availability of N95 masks and gowns and other equipment, and certain availability was also an issue because the supply chains were also affected. Then the government asked for a reduced number of team, 50% presence. So that also led to the team fatigue, as well as people, since our weathers are tropical, wearing such PPEs, especially in a non-air conditioning setup, was also very fatiguing for the team. And that led to a lot of psychological stress and burnout in team. So that's the reason surgery during pandemic remained a great challenge. But unfortunately, this has to carry on because we could not have stopped the emergency surgery. So all emergency surgeries, both trauma and non-trauma, were continued in our hospital. The only thing is that we developed the COVID ICUs, a COVID operation theater, as well as we have a specialized team for the COVID patients We did not use any COVID testing for the emergency patients because they were treated as they come. And later on, if they found to have COVID positive, they were shifted to COVID ICUs and or HDUs as per the needs. The hospital and the government banned all the elective surgery initially, but later on, when you had a lot of burden of the cancer cases, we basically rationalized the elective surgery based on the medical necessity and time sensitivity index. And this time's medical necessity and time sensitive index, as developed in America, was very helpful in telling which patient is going to really benefit from the surgery based on his medical necessity and time sensitivity. And this was especially applicable for most of the cancer surgeries. Although we used radiation for local treatment and chemotherapy in most of our patients just to delay the surgery, but eventually those patients ultimately had their chemotherapy and radiotherapy and needed surgical control. And this surgical control, this MENT score helped us in proceeding this. We also use MENT score for certain patient in which intestinal obstruction or obstruction of the biliary passages or incisional hernia basically was making them a doable surgery, but these were usually sent to emergency. So elective surgery was primarily cancer surgery. Cancer patients were operated in the emergency, and majority of them had complications like obstruction or perforation and bleeding. Some colorectal cancer were also operated in the elective OR, and all patients who underwent elective surgery had a PCR before surgery, and a compulsory vaccination was initiated after July 21st. And all surgical staff were started vaccination in February 21 and were fully vaccinated by July 2021. No, for the elective surgery, since July 21, we have the compulsion of having a PCR before the day of surgery. We have now started all sort of elective surgery, and later on, I mean, we also have made the immunization certificate compulsory for both doctors and patients as well. So now let's come to the results of the surgery which we have done since from March 20 to October 21. The rest of the surgery was as usual. The mortality in typhoid perforation or other perforation, peritonitis, and intestinal obstructions were the same as before. But what we found that when we had this colonic obstruction due to cancer patients were sent for emergency surgery, we had almost 60% loss of surgery in such patients. And these post-emergency COVID patients was isolated in COVID HDUs and ICUs. We had almost 10% patients, 10 out of 50 laparotomies which were done in ER died and they were found to have a COVID positive. But we do not know whether this is because of their COVID condition or because of their digital pathology, which has led to death of this. So elective surgery, only PCR negative patients were operated electively. None of the doctor got infected because of acquired infection from the patient during surgery. The operative mortality model was similar to non-COVID era. We operated about 21 colorectal cancer. All of them had completed their neoadjuvant or any neoadjuvant chemo or radio if they're applicable. We operated on periampullary, and all of these periampullary had their ERCPs done. And we operated on 5 sarcoma patients. After the July 21st, once we have this vaccination completed, we have started all the elective surgery, both hernias, lap polyps, and cancer in this COVID era. Although during that period, we had this fourth wave, but we did not stop, and we did not find any mortality in COVID patients who were negative. And I think this might be related to most of the patients who are vaccinated, and as well as most of the surgeons who are also vaccinated. Now, except from the higher mortality in emergency colorectal cancer service, we didn't find any difference in the mortality of our patients. But this is a data from one of the hospital, the Gutti Hospital in Lahore. They did not stop their elective surgery, and I requested the head of the orthopedic department, Dr. Ameziz, to share his experience. So he sent to me, they did 11,000 elective orthopedic surgery cases in the last almost 2 years during the COVID pandemic. They only did PCR or HRCT in suspected patients, and 200 doctors out of 240 of their doctors got infected while managing these patients, and they were treated home. There were more mortality in the doctors. And they claim that none of their patients died because he was COVID positive. They died just because of their own pathology. So to conclude, a Pakistani experience is slightly different, especially in our setup, slightly different. The reason was there was less number of patients coming to the emergency services. People trying to stay at home. That's why that led to decreased number of trauma coming to the hospitals, as well as the usual mortality was related to the original pathology and not because of the COVID. Although in emergency surgeries, we found that we had a higher mortality in patients who had emergency cancer surgeries done. The main challenge remained was how to mitigate the risk of cross-infection from patient to surgeon and vice versa. And the availability of PPEs was an issue both financially, but there were many donors agencies who helped in this regard. Screening, immunization, and using protocol like MedScore did help in the execution of surgical services. And one of the byproduct of this whole 1.5 years or 2 years is that all these surgical staffs have learned the importance of hand hygiene and face masks. And I think this should remain an essential armamentarium of all the surgeons even afterwards. I thank you very much.
Thank you, Professor Afzal, for that sharing that experience in Pakistan. It's sad to come to know that a fair number of medical personnel has succumbed to this virus.
Yeah, thank you, Afzal. Our next speaker is Dr. Arunajit Piris. He's a consultant general surgeon currently working in Base Hospital, Paranadura. During the peak of the pandemic, he was a consultant surgeon in Base Hospital, Homagama. So where one of our Base Hospital Homagama was one of our COVID centers at that time. So he has enormous experience in managing COVID patients. Arunajit is a consultant general surgeon with laparoscopic colorectal interest. Over to you, Arunajit, for your share your knowledge with us.
Okay, thank you. Chairperson, sirs, distinguished delegates, and my dear teachers and colleagues. So this short presentation is based on my experience I had when I was at Base Hospital, Homagama. In 2020 March, our hospital was converted to a hospital dedicated to management of COVID-19 patients overnight. And we were instructed to stop all services given so far in the hospital. And we actually did even up to esophagectomy at our hospital. So, all involved patients were transferred to other surgical hospitals, mainly the Colombo South Teaching Hospital, and our interns, all interns were attached to Colombo South Teaching Hospital. 8 SHOs we had was taken into common COVID roster. At this time, we didn't have any surgical patients. It's most of the time asymptomatic patients. Then we had 2 registrars needed to get attached to other hospitals. So they were only had about 2 months experience with us. And there was an orthopedic registrar who was supposed to come for general surgical appointment to me in April, and I don't know what happened to him. And 2 surgeons became jobless. So what was our duty? Giving instructions in making infrastructure, finding donations, attending to occasional surgical referrals from the COVID wards, attending to various meetings with the ministry, and fighting all the time with the ministry to start normal functions while managing COVID-19 patients. So after 4 months with the first wave weaned off, we were able to start some normal functions. So we got our house offices back with great difficulty. And new registrar also came. But we were only able to function for about 2 months. So then came the second wave. We were converted to a multidisciplinary COVID management center with the we needed to manage the surgical patients as well. Now the hospitals were fully converted to a COVID hospital, and likewise base hospital Mull area was also converted to manage surgical patients. So COVID contracted surgical patients were transferred to base hospital Homagama from all over the country, even from Jaffna and from Batiklo. So some patients were managed, initial management was done at relevant hospital and then transferred to us, and some were not. So these patients mainly had chronic wounds, and there were several patients with following trauma, and a few patients with appendicitis and acute abdomens. So how did we manage these patients? So they were separated with the glass windows, and staff was on the other side, and we used to use a phone to communicate with the patient, and later on we used to open up the doors and then windows and directly speaking with the patient with 2 meter distance. Later in some patients we had to go with the full PPE, and examination was also done in some patients through the glass using CCTV cameras. So when a doctor goes in and take the photographs with the consent of the patient, it was put into a common WhatsApp group who manage the surgical patients. And there was a pair of rubber gloves attached to the fixed to a glass, and we were able to examine the patients on the other side of the glass without we going in and putting our hands into that gloves. So likewise the radiological colleagues did their radiologists ultrasound scan like that. So in some patients definitely yes, we have to go with the full PPE to have a proper examination where necessary. So as I said, we had a lot of wounds. So in normal practice, nurses do wound dressings, but here the surgical SHOs had to do the wound dressing, of course with the help of the nurses. So regularly we did wound debridement in theaters. Very occasionally we had to do amputations, laparotomies and appendicectomies. So this is giving assistance to a patient with full PPE. So this is a tracheostomy done in the ICU without any lighting and without the help of the diathermy. So this patient was quite fat and could not extend the neck, also very short neck, and he started to bleed. So I have to take off my goggles, and because visibility goes down and I have to take my goggles and my spectacles, I proceeded and managed to stop bleeding. Patient survived later on from COVID, and so I am much happy because I put myself into risk and saved this patient. So I had to get quarantined after this operation. This is a laparotomy done in intestinal obstruction with a malignant tumor in the rectum. And so this is wound toilet or wound debridement done in theaters by SHOs. So this became day-to-day life. So what's happened when this comes into our day-to-day life? So frustration sets in. So why we get frustrated? So breaking of doctor-patient relationship. They can't recognize us when we are in full PP. Histories are very short, examination short. So we have to finish because the visibility goes down and you become exhausted with full PPE. So, and when we are on the other side of the glass speaking to them, that also, I mean, definitely they will not have faith on us. So unable to attend to some issues of the patient, and these patients had a lot of family issues, and even we can write a book on this. And so though, I mean, there are a lot of things he need to listen to, but we can't do anything for them. And of course, some patients died with the peak of the COVID-19 pandemic. At this time, it was a lockdown, but we were happy to have a lockdown other than getting patients and seeing more deaths in surgical wards, because we used to, I mean, our mortalities are in surgical wards are very much less. So I had to get self-quarantine for thrice due to exposure. And so some of the patients who were transferred to us needed specific definitive treatment like vascular intervention and internal fixations and so on. And to transfer these back to particular centers, we needed a negative PCR. So in some patients it took more than 1 month. And later on it was changed to 2 weeks. And but still, it's 2 weeks is a still long period. For example, for a fracture femur lying in a bed without any assistance. Trauma patients, on the other hand, with the short experience we had with the normal functions, there were several trauma patients died in front of our hospital who couldn't come to our hospital because it was fully closed for COVID patients. And wounds were neglected and malignancies got advanced. So for these reasons, anybody, I think, experiencing these things will get frustrated with time. So what is my message? COVID-19 contracted patients should be managed by each and every hospital while managing other patients. Thank you. About this picture, it's Angam Madilla, where the Kim Parakrambahu had diverted water from the river Mahavali to Parakrama Samudra tank. So on the other hand, I can say this is the ministry converting COVID-19 patients to our hospital and IDH and base hospital Mull area. Thank you.
Thank you very much, Arunajit, for that presentation with provoking thoughts. We can have some discussion. Let me ask all the presenters to be online. At the end of this next talk, we will have a discussion on this topic and highlight few important issues. What do you say?
There's a communication failure with Mohammed Soli from Maldives and Dr. Ahmed Javid from Afghanistan. So the next speaker is going to be Dr. Dcis from Mysore, Karnataka. He's a consultant laparoscopic surgeon. I remember in, I think, 2016, when the ASI conference was in Mysore, we met him, and I hope that he will be visiting Sri Lanka next year. Over to you, Dr. Sidesh. Until he's online, can we
start a discussion? Is Professor Alamgir, are you with us, Professor Alamgir? Okay, let's, Arunajit, now you have highlighted some important practical points. Now, apart from these clinical scenarios, there are some other issues with regard to surgical training. I know that there were some trainees allocated to your hospital. What can you elaborate what happened to them during this period?
With the first wave, when we were converted to just a COVID management center, in that time only asymptomatic patients were sent. There was no surgical patients at all. So I had to guess. So I spoke to a postgraduate center, and then we were able to manage. We were able to get a place at Mathura for my registrar. He was just finishing 2 months when this COVID pandemic came. So so I don't know. I mean, he had only 2 months with me, because peripheral important is so much important for a general surgeon. So there are a few trainings before that, so they were quite happy getting training at base hospital Homagama. I had regular registrars coming to me during that period, and there was even overlapping also.
Yeah, actually, even the other hospitals, now for example, Colombo South Teaching Hospital, we had to stop all the routine work, and then exposure to routine surgeries were completely abandoned, and they didn't get any exposure. So therefore their training is affected significantly over the last during this pandemic. Not only that, I think, what about your experience in medical student teaching? Now I know the Homagama Hospital is a teaching hospital.
I forgot that as well. So we had medical students coming from Sri Jayawardhanapura for surgical training and surgical appointment, and unfortunately that also came into hold. Still so it's not open for medical students.
I think Bhamanta, being a professor in the teaching hospital in a Colombo South Medical School, what experience you have with this training of the undergraduates and as well as the postgraduates.
Yes, sir. The undergraduate training we now in a university setup when COVID hits, it's very difficult to manage the student population. So we had to close the university. However, we as far as the medical faculties are concerned, we want to start the training because medical curriculum is very tight curriculum. If you miss out a segment, it's going to affect their future. So with all the difficulties, we managed to start the medical curriculum, but time to time it got disturbed. Now Sri Javadanpura Medical School sends their medical students to base hospital Homagama, which was converted to a COVID center, and several other hospitals. So most of the hospitals didn't want to get the medical students because then if they get exposed, then spreading is going to be very vibrant. So their training is affected a lot. Not only that, then the surgical trainees, as I elaborated earlier, routine operations were abundant, therefore their exposure to routine surgical procedures were actually marginalized. So that definitely would have affected their training, and it will reflect in their training, I think. So not only that, sir, now Arunjit highlighted another point when now he was quarantined, I think 3-4 times. So that affects surgeons' family life also. So those are the other side of this COVID pandemic. Their family life is affected, and in this part of the world, surgeons depend on private practice for their earnings, especially in our part of the world. So those things also significantly affected, I think, during the pandemic. What do you think, sir?
Yeah, exactly. I mean, all were affected, and fortunately, I mean, the medical profession is in a better status compared to the average daily paid people. Bhavanta, how about the exams? Were they held on time or as scheduled? Or
undergraduate exams, no, sir. We had to postpone exams. And now, since we are coming out of the pandemic, we have started having our exams. Therefore, there will be in future lag period. Now, as we know, once the students complete their final MBBS exam, there's an internship. So there will be some issues in getting the internships on time because of this. And the postgraduate exams also, we had to postpone several times. So we couldn't do the postgraduate exams on time also. And the other thing is now Sri Lankan postgraduate exams, as you know, we have always the overseas examiners coming in. And during this pandemic, we couldn't get them physically. So there were some issues as well in conducting the exams.
And some of most of the senior registrars couldn't go abroad for their overseas training also.
Yes, exactly.
I think some of the final years of pre-interns were employed as COVID staff to the COVID hospitals, isn't it? Over to you, Dr. Sidesh. He's from Mysore. He's a consultant laparoscopic surgeon.
If you can see me, yeah. Okay, thank you. Sorry for all that. I was logged in, but I didn't get this particular somehow the link anyway. Thank you for this opportunity to share some of my views on the challenges we have faced during the COVID pandemic as surgeons. I bring greetings from Mysuru. As been told by my dear colleague, you know, Mysuru is a beautiful place of gardens and palaces. I invite all of you for the next time you have an opportunity to visit. I share the same views that Because of this pandemic, we are unable to meet physically. I bring greetings to all my SARC colleagues and especially the members of the College of Sri Lankan Surgeons for this wonderful meeting and giving me this opportunity to be with you. The challenges, of course, in COVID-19 has been highlighted by my colleagues earlier, is as a surgeon to deliver the safe surgical practices amidst the 19 with the minimizing the risk of spread of COVID-19 in the hospital. And we also should know that the cost is another issue. Of course, in India, the whole cost of managing the COVID services was met by the government, even in the private setup. The preparation, of course, any challenges when we need to meet, we need to have planning. And the planning needs to be in the form of developing multidisciplinary teams and developing protocols. And these protocols need to be redrawn. And we had to do repeated meetings over a course of months where we need to change the whole protocols many times depending on the new scenarios which we have to prepare. The reason being, we all know we are all inexperienced in this pandemic. So this has been all new experience, and we had to keep on changing these protocols. And another challenge is to train our staff. Training the staff to meet up these protocols is another challenge altogether. And again, these staff need to be made to relearn and unlearn and again relearn. So this is a challenge again. When it comes to the OPD, as been told earlier by our colleagues, the OPD numbers were significantly less compared to earlier because of various reasons, not in our capacity. But at the same time, whatever group of outpatient numbers, we need to take care of the high risk group, and we need to keep a separate outpatient space to see the patients having suspected symptoms of COVID, and also with a proven report of COVID had to be segregated. We have to always remember what we found. The most unsuspected, our own colleagues were the spreaders. We don't know. We always assume that our colleagues are safe, but they ultimately will become the spreaders. We need to be careful about this. Elective surgical protocols, we try to reduce the numbers as much as possible and defer the surgeries. There, the advantage of deferring surgeries, reducing the numbers for each list, came with advantages of less transmission, less risk of transmission. We had more staff and critical care beds available for COVID care patients. And what is most important is our sharing the anesthesia colleagues who are well trained in maintaining the airway for in the critical areas. So that is how we need to reduce the numbers of elective procedures as much as possible. For doing that, we need to prioritize which of these patients which you can postpone. So that require team meetings, and we need to counsel the patient about the risk of postponement versus the risk of contracting the COVID disease. This is a very hard job, as we all know. Of course, cancer surgery has been to be kept as one of the priority on the list, but at the same time, we need to have team meetings with multidisciplinary specialities where we can think of advocating neoadjuvant protocols which can postpone surgeries with the same result. And again, this requires patient counseling. And in trauma, of course, we had less of trauma reporting to our hospitals. The reason being the movement in COVID was much less. At the same time, we can think about instituting conservative measures, treatment protocols, instead of operative protocols when there is a choice, even in trauma and wound healing surgeries. Emergency surgeries, when they become inevitable, like in a patient who is suffering from COVID-19, develops acute necrotizing enteritis, necrotizing pancreatitis, and ischemic bowel, which we saw as an rise in our experience, they required, but at the same time, we need to have a plan that the survival benefit has to be weighed about the risk of spreading the disease, because most of these patients were associated with very high mortality. In some of our patients who have been operated, elective patients, they contacted COVID in the ward. So one has to be very careful in trying to identify the earliest symptom and subject them for testing and retesting whenever required with a high degree of suspicion. We need to select an operating room which is close by to the ICU so that we can minimize the movement of COVID-infected patients. We have to use bare minimum equipment so that they don't get contaminated. And whenever you use such equipments, we need to use strict protocols of disinfection at the end of the procedure. As been expressed by our colleague, personal protection equipment gadgets had to be very judiciously used, but at the same time, we need to protect our colleagues, so we need to have them available in plenty. Lucky, even Association Surgeons of India, under the then President, Dr. Raghuram, came in handy with distribution of free personal protection equipments to surgical colleagues with a distribution system. This was taken up by Association Surgeons of India. Proper care of biomedical waste management was another big challenge. Is one of the procedures. Yeah, we need to evolve teams, individual teams, and we need to take care that these members of each team don't crisscross in their postings. But it is very hard in the times where absenting was a rule than an exception. Hence, we need to set up goals which are realistic. Of course, we need to be meeting up the numbers, but we have to be also realistic. We need to educate the staff, even during when they are off the duty, to observe the protocols, not to come in contacts. This is again another hardship. We had to train these staff. So most important was to maintain motivating these staffs time and again, because they get demotivated, they get mentally wrecked. So they need to be counseled. We had an opportunity to rope in our psychotherapy colleagues to motivate our staff who are working in the COVID wards. In conclusion, I would like to say in our experience, COVID-19 pandemic has posed serious challenges to us, and absence of clear guidelines and lack of experience compounded our situation. Building collaboration is the best way we found to look forward. Teamwork with all our colleagues, forming our protocols helped us. Documentation and sharing may help in managing these issues. So today we are here to share our views. Let us share to save more lives. Thank you very much. I again bring greetings from Mysuru, City of Palaces. Thank you for this opportunity, Bhavanta, and all of your colleagues. I bring greetings. Thank you.
Thank you very much, Dr. Siddesh, for sharing your experience, the challenges, and the solutions. I remember your great hospitality when we visited Mysore in 2016. Thank you very much.
Yes, you're right. You're right. Thank you. Thank you.
Thank you very much for all the participants. This concludes the symposium on SARC Symposium. Let me hand over to you. Thank you.
Thank you, Chairperson, sirs. That's Dr. Narendra Pinto and Professor Bhavanta Kamage. Ladies and gentlemen, let me welcome back the delegates who have been at this parallel symposium session. We are about to start the plenary number 10 of the Sri Lanka Surgical Congress 2021. May I invite on stage Dr. Mahanama Gunasekara and Dr. Jayantha Fernando onto the stage to invite the guest speaker for the plenary session and the very interesting and timely topic that will be relevant for the surgical fraternity of Sri Lanka.
Good morning, colleagues. I have the privilege of introducing one of our senior surgeons, Dr. Nishanka Jayawardena, who needs no special introduction to this audience. However, he is one of the general surgeons who has worked hard to improve the quality of surgical care as well as quality of life of surgeons together. And he was one of our past presidents, and however he's still active in health policy reforms and advising the ministry constantly on, particularly on matters related to general surgeons. So Nishanka's subspecialty interest is breast surgery. However, today he is going to talk about a topic which is unique to Sri Lanka but could be used as a model for anywhere in the world. Over to you, Nishanka, to talk to us on the hospital.
Thank you, Mahanama. Good morning, ladies and gentlemen. I would like to quickly go through what I mean by cluster system and general surgeon with a special interest. In this, I would like to talk a little bit about the evolution of general surgical services of Sri Lanka, the need for changing into a degree with a special interest. Now, as you know, all our general surgeons are getting a degree with a special interest, like in developed countries. The problems faced with the implementation of this system and how to develop a simple and a low-cost method, because we are still a developing country and we don't have money to spend leisurely, to share both human and other resources by the proposal of hospital clusters to help them practice with the interest, a special interest. When you take the recent history of surgical qualifications, up to 1953, we did not have postgraduate qualification of surgery or any other subject for that matter. We always considered the doctors who went abroad, mainly to UK, and got fellowships, and when they came back, they were considered as consultants and they were appointed to the government hospital. Now, I'm mainly addressing about the government hospital system here, because that is the main hospital system in Sri Lanka, where about 90% of the general surgeons are employed. So in 1953, Faculty of Medicine Colombo, a prestigious and the most ancient faculty of Sri Lanka, started an MS surgery degree. However, that degree, I think, did not catch up, and it was not considered a true qualification for the appointment as a consultant. Then in 1973, the Advisory Committee on Medical Education recommended the government to establish an institution for postgraduate medical education, which was timely because all the other countries were doing it. And also in 1972, there was a constitutional change where we were under British dominion, and then we became truly independent in 1972 with the change of government, and this would have initiated this move to have our own degree. Then in 1976, Institute for Postgraduate Medicine was established. However, it was not legitimized by the Parliament. So in 1980, by the Parliament Act of Postgraduate Medical Education, Postgraduate Institute of Medicine, or PGIM, which all of us are very familiar, was established. And PGIM first awarded MDs medicine, and the next year it started awarding MS surgery. And this was duly recognized by the Ministry of Health for employment, which turned a leaf in the surgical surgeons' employment. So once, and also the general surgeons who started as anywhere in the world, general surgeons who started doing, who were doing from head to toe surgery, branched off into ENT, orthopedic, GU, neuro, cardiothoracic, which later divided into cardiac and thoracic, and then later emergence of onco, GI surgery, vascular, transplant, and so on, these specialties. But however, there were few problems we had to address. Who will handle emergency admissions? And what units would be accredited to train undergraduate and basic postgraduate students or trainees? Then how would general surgeons who are entangled in daily admissions, doing everything, would manage to enhance their skills and knowledge to match the expanding knowledge of medicine and expanding horizons of subjects and to match the international standards? So that was a problem with the general surgeons. Some specialty surgeons serving in central and peripheral hospitals did not undertake the responsibility of attending to emergency admissions. Who did respond to emergency on call then? It was the general surgeon who did most of the emergency on calls at that stage. And fortunately, most of the if you can call it subspecialties, but I would call it other specialties, non-general surgical specialties, they also started looking after their emergency patients. So general surgeons bore the brunt of the surgical, as I said, workload, especially in the peripheral stations. They were doing, when I was a general surgeon in the peripheral stations, I was doing mostly closed manipulations of almost all the fractures, compound fractures, and open GU surgery, and so on and so forth. Even burr holes people are doing, I of course did not do, but we were handling almost all the specialties as well. But that was not the optimum. And almost all emergency surgical services and many routine surgery and the major proportion of cancer surgery are done by the general surgeons, even up to date. Introduction of a special interest to upgrade the standards to match the modern day and to maintain training opportunities abroad was essential at this point. As Professor Mohan Disil was saying, a specialist during the day and the generalist at night. That was the need we wanted. Then, having all this background, a new curriculum and a new degree we wanted, and Specialty Board of General Surgery was established in 2010. Professor Mohan De Silva pioneered as a chairman, and Dr. A.S.K. Banagal as a secretary, and a group of young general surgeons whom I see here, as well as I was young then, so I also belong to that young category. So was Dr. Mana Gunasegaran. He is still young. So, and then we devised 7 special interest areas. Now, these are the special interest areas, I don't have to repeat. This added 1 year extra training to the training and making it compulsory 3 years and optional 4 years. And this made it comparable to the specialist surgical training, putting us on par with the specialist surgical training of other subjects. However, our first batch of trainees who passed out as a special interest, with a special interest in 2015, had to face a lot of dilemmas as surgeons because they were a new breed and they didn't know where they stood. We also didn't know where they stood. Most of them were given appointments as consultant general surgeons in government hospitals, mainly in the peripheral and less popular stations, and rest joined the universities, army hospitals, and private hospitals. Many had minimal facilities to interact with each other, little opportunity to have specialized services and MDT meetings, and to practice what they learned in their special interest training here and abroad, which was depressing. They had minimal senior support at this stage of their career, which needed it most. So, Bingumal Jayasundara, who was a special interest trainee at this point, did a study. And these were the conclusions. Less than 50% of the trainees were satisfied with their special interest training. Colorectal specialty trainees selected to university units were more satisfied. Employer not recognizing, that is the ministry, not recognizing this system which changed was a major concern among trainees. Limited minority of trainees believed to have the opportunity to function with their special interest in future. Trainees doubted personal career benefits of or patient care improvement from this change. This is a better system that this is a better system at all. Majority of acting consultants would have opted general surgery without a special interest if the provision was available. So that was the pathetic situation we were in. Initial problems as a general surgeon who develops a special interest, which I did in a peripheral hospital, was developing a critical mass of patients. You don't have enough patients to develop practice your skills as a special interest surgeon. Then you don't have support staff, specific support staff, and you don't have enough equipment. So you have to get around all these when you want to develop a special interest. So the challenge and responsibility of all general surgeons, us, to help overcome the problems faced by a future generation of general surgeons by devising a system to maximally utilize available resources, both human and material, help to develop critical mass for each surgeon, formation of MDT meeting, provision of opportunities for CPD, maintain a suitable training substrate for the special interest trainee, serve the needy, that is the patient, day and night. So this was something conceived by us to have a cluster system, to select a group of closely situated hospitals with a consultant general surgeons as a single cluster with a view of sharing human and other resources. Intra-hospital and inter-hospital transfer of selected patients to the surgeon who has the particular interest for optimum management. MDT meetings to involve the entire cluster and all general surgeons to treat trauma, other surgical emergencies, and all straightforward general surgical procedures they are confident of doing. So you're all familiar with this government, the hospital system or healthcare system. We are interested in this group, target hospital, where we have district general hospitals and district base hospitals A and B. We have 19 district general hospitals with 2 to 3 consultant general surgeons with other specialty support and good infrastructure. 27 district base hospitals with 2 consultant general surgeons with acceptable other specialty support and reasonable infrastructure. 44 district base hospitals, B, 1 on no general surgeons, little other specialty support, and variable, mostly inadequate infrastructure. However, these are the hospitals. It's studded. The Sri Lanka is studded with these hospitals. They are situated so close by. These are geographical location. So we would suggest general surgeons in a province district, except teaching hospital and provincial hospital, which is a different kettle of fish, where I believe all specialty interest surgeons should be there. Hospital taken as a cluster, these hospitals, which should have surgeons with various special interests. To advertise general surgical post according to this in annual transfer list, because we qualify people with a special interest and then, we just drop them. They don't know what to do unless the employer advertises according to that. But having said that, I'll come back to it again. To encourage inter-hospital and intra-hospital referrals of the more complex cases to colleagues with the relevant special interest. To provide minimum required facilities to all hospitals with general surgeons and more advanced and expensive specific equipment to be provided to the allocated hospital with the other required infrastructure to be shared by all the hospitals in the cluster. To share the human resources in the absence of such in a particular hospital. Surgeons with trauma interest to be appointed to trauma centers and major A&Es. All national teaching provincial hospitals posts to be advertised according to the special interest. So we have a lot of challenges to overcome. How to incorporate the surgeons who have not declared special interest in the system, those who have qualified earlier. Discuss with the stakeholders, Ministry of Health, PGIM, major trade unions, affected surgeons, of course. Can we encourage all general surgeons to declare special interest of their own within a stipulated time frame? We have to give them a stipulated time frame and ask them, look here, chum, we give you 5 years or 10 years. After that, this system is going to change. Then they have to develop and they should be given a freedom to practice a special interest. So this has to happen, otherwise the system will not go on. All efforts should be made to improve the general surgical training to match that of the accepted high standards of care. These changes should occur, unlike the fertilizer, after discussions on a broader forum with all relevant parties, gradual transition with reasonable time frame, and probably in stages. However, the factors in favor. We in Sri Lanka have a good road and highway system with easy access and well-organized ambulance system. Same employer. Surgeons and other staff with identical equivalent qualifications in all the hospitals and knowledge and skills. Free for all health system in the country, and most of all, small surgical community with good interactions, and we all are friends. So it's so easy to do it. It should be so easy to do it. And to make it a success, what needs more? Thank you.
Thank you, Nisanka, for that excellent presentation. I know it has been your passion for the last few years, and we hope that the future college presidents will advocate this with the ministry, and someday it will become reality. Thank you very much.
Thank you, Chairperson sirs, Dr. Jayendra and Dr. Mahanab Gunasekara. So now we break for tea. Since we are running a little short of time, we would like to start exactly at 11:15 with the next plenary session. So have a quick tea break and come back to us. Good morning, everyone. Thank you for being back soon after the tea break, so we can start our proceedings for the next plenary. It is going to be plenary number 11, and it will be chaired by two eminent surgeons, Dr. Arunjit Piris and Dr. Samir Jayasinghe. Over to you, sir.
Yeah, welcome to the plenary 11. The speaker is Dr. Duminda Ariyaratne. He is a consultant general surgeon from the National Hospital of Sri Lanka. And the topic is going to be on COVID-19 guidelines of the CSSL and its impact on surgical services. In fact, Duminda has first-hand experience in managing surgical conditions of COVID-19 patients because he was the surgeon at Colombo East Base Hospital, Mulleriyawa, which was a COVID hospital. So, over to you, Duminda.
COVID-19 guideline document of the College of Surgeons of Sri Lanka and its impact on the surgical services of the country. COVID-19 and the Sri Lankan surgical services. First patient of COVID-19 detected in Sri Lanka on the 29th of January 2020. By 31st of March 2020, there were 222 cases and 2 deaths recorded. Initially, COVID patients with surgical problems managed in the National Institute of Infectious Diseases and outreach services were provided by the surgeon of the Colombo East Base Hospital. However, as the patient numbers were increasing, the Colombo East Base Hospital was designated as the first surgical COVID hospital. We admitted our first surgical patient on the 31st of March 2020 that was a 78-year-old female with necrotizing fasciitis of the leg. We successfully managed this lady and she was discharged home. We in fact reported this case in the Sri Lanka Journal of Surgery. Institutional concerns. Although we managed this patient quite successfully, there were few concerns which arose. Limited knowledge of the disease and its infectivity. There was no effective vaccine at that time. Non-availability of specific advanced surgical care facilities such as negative pressure air exchange systems, etc. was not in place. Inadequate capacity for isolation of patients. Limited availability of ICU, SDU and subspecialty care. Limited facilities for advanced imaging and other investigations, and last but not least, non-existence of national or institutional guidelines in patient management. Since then, we had referrals from all over the country, and primary reasons we realized for these referrals was lack of knowledge in managing this unprecedented disease entity. This matter was discussed with the Council of the College of Surgeons of Sri Lanka, and then the then President Dr. Jayendra Fernando appointed a subcommittee to draft COVID surgical guideline document. This committee comprised of Dr. Mahanama Gunasekara, Dr. Nisanka Jayawardena and myself. We perused international guideline documents and we did liaison with the international professional colleges. In order to adhere to cultural relativism of Sri Lanka, we felt that we need to draft our own set of guidelines, and we evaluated the regional hospital resources and collaborated with surgical colleagues all over the country. COVID-19 affecting surgery was taken into consideration when drafting this document. We felt that there was delay associated with screening with COVID-19. We realized that there was a need for extra resources for positive patient management, and risk of disease spread among the healthcare workers and among the other patients, fear of stigmatization and discrimination as experienced by the patients, and support systems from others like extended family and friends was affected. As you are aware, in countries like ours, we have a lot of support coming to the patients from the family and the friends, and that was limited due to this disease entity. Effect of COVID infection on the outcome of surgical diseases and reluctance of the healthcare workers initially to expose themselves to COVID, compromising the optimal care, were some of them. And these are the COVID guideline documents, that some of the documents that we perused. An initial guideline document was published in April 2020. Mind you, this is just 2-3 weeks after admitting the first patient. The prime objective of this document was to standardize surgical care island-wide during this turbulent period. We also made it a point to say that this guideline had to be considered in conformity with the institutional capabilities and at the discretion of the surgical teams concerned. The document had 3 components: aims, classifications, and recommendations. The aims the primary aims were to minimize the mortality and morbidity of the surgical patients, both COVID and non-COVID, due to delay or denial of instituting treatment. To prevent, minimize the risk to the patients and staff acquiring COVID. To support the stringent COVID control program, to optimize the usage of PPE and other material, to classify surgical patients taking into consideration their COVID status and priority needs were some others. We did a classification of the patients and made recommendations accordingly. These guidelines had to be subsequently revised, and I will come to them as we go along. This is the numbers of admissions that we experience in Colombo East Base Hospital. As you can see, this is the first wave up to September 2020. The second wave, there was a peak, and the third wave from April 2021, there were increasingly patients being referred to this hospital, despite the patients being managed in the peripheral institutions. So we felt there was a need to revise these guidelines 1 year on, primarily due to increased caseload and better understanding of the disease, emergence of new data internationally, impact of an effective vaccine, and availability of rapid antigen testing, which was not there earlier, and regional hospitals, as I mentioned earlier, managing COVID patients quite successfully by them. This is some of the information that we gathered. And this revised guideline document was published in May 2021 under the presidency of Professor Srinath Chandrasekhara and the Council of the Golden Jubilee of the College of Surgeons of Sri Lanka. Aims again more or less remain the same, and classification of patient categories. We had 5 categories of patients. We wanted to make sure that there was minimal or no chance of cross-infection among the patients or from the patients to the staff to maintain safety of the hospital environment. Category 1 was PCR negative patients. Category 2, RAT negative asymptomatic patients. Category 3 was RAT negative but symptomatic or close contacts of COVID-19s. Category 4, RAT positive patients awaiting PCR confirmation. Category 5, confirmed, PCR confirmed positive patients. Prioritization of procedures. The type 1 procedures were considered as emergency surgical procedures, which are limb-saving, life-saving, or organ-saving. Type 2, oncological electives. Number 3, disabling non-oncological electives associated with significant morbidity and mortality if treatment deferred. This category included obstructing hernias, symptomatic gallstone diseases, and so on. Type 4, surgical procedures which could be safely delayed, the procedures that we call as cold surgical procedures. So the first recommendation that we made with regards to allocating designated areas within the institution. Wards, theatres, ICU, and HDU. In the wards, we wanted to make sure, as I mentioned before, the safety of the patients admitted to the hospital. All the patients should be screened with rapid antigen testing prior to admission to surgical wards. And we recommended to have a PCR positive zone for patients and an intermediate zone of patients awaiting PCR screening and PCR negative zone. In the theatre, similarly, there had to be dedicated operating theatres for category 1, that is emergency surgical procedures, and category 4 and 5 emergencies of category 3 patients. ICU, HDU, again, there had to be designated areas for patient management. Recommendation 2, surgical procedures. We reiterated that the priority must be given to type 1 emergency procedures and should be attended without any undue delay, irrespective of the COVID status of the patient. Emergency surgical care should not be unduly deferred for laboratory confirmation of COVID-19 status, and such instances we recommended to consider them as COVID-19 for COVID-19 positive for all practical purposes and to treat them without any undue delay. And recommendation 2C was whenever possible, non-surgical management strategies or modified procedures recommended based on universally accepted guidelines. Elective procedures, of course, could be deferred until their PCR status was known. Recommendation 3 was with regard to the attire. Initially, we defined what the proper PPE should be: surgical mask, goggles or glasses, impermeable apron which goes beyond the upper border of the surgical boots, and then surgical gowns with gloves, and basic PPE even for PCR negative patients. Type 1 procedures, emergency procedures, should not be delayed due to non-availability of a particular brand of PPE, and to use whatever is safe and effectively and what is readily available. Demand for PPE should be ethical, justifiable and subject to availability. It's noteworthy that we never ran short of PPE in this country at any time. The most important factor is the impact which this document made to the surgical services of this country. We are happy to note that despite this calamity, we were able to maintain essential surgical services in this country. We were able to alleviate fear psychosis and build confidence among the staff. I remember initial surgical procedures of all the PCR positive COVID patients were carried out by myself. But as time passed, my junior staff developed confidence in operating on these patients, and they took the upper hand in managing minor surgical procedures under my supervision, and it was like really interesting teamwork that was in operation. The optimal usage of resources like PPE, etc., which was evidenced by the fact that we never ran short of any PPE in this country anywhere. Eventually, we were able to treat patients in their own locality, thus making it cost-effective and minimizing inconvenience to all. Gradually, we were able to restore surgical services in the new normal environment. So, right around the country, there were surgical procedures carried out in the new normal environment, thanks to the surgical teams of the country. This is a graph which I thought I should share with you all today. These non-COVID procedures that we carried out in the Colombo East Base Hospital parallel to COVID surgical procedures. On the left-hand side, this graph shows that there are time periods where we did not carry out any non-COVID procedures. That is primarily due to the fact that the hospital was shut down for non-COVID admissions by the Ministry of Health as the COVID numbers were going up. So apart from those two periods, the rest of the time we were carrying on with our non-COVID procedures as it was possible. And this is the patient admission curves for your information. And I must thank the College of Surgeons for allowing us to produce this guideline document, the College of Surgeons, President and the Council, and then the surgical teams right around the country for doing an excellent job of work during this turbulent period worldwide. Thank you very much for your attention.
Thank you, Dr. Dominder. And I must thank you for the excellent job you have done during this COVID period, because I know I also have got advices from you. We were the second center for multidisciplinary COVID management. So as you are the first one to do that, you can remember we have spoken with you in situations where we needed advice from you. So thank you very much for an excellent presentation. Okay. Questions to be asked? No questions.
So after this, we have a very interesting symposium again, symposium number 8, and it will be chaired by Dr. Nisanka Jayawardena and Dr. Andima Nanayakkara. Over to you, Chairperson, sir.
Good morning again. This is the symposium on breast surgery. I would first like to call upon Dr. Ajit De Silva, Consultant General Surgeon, National Hospital of Sri Lanka, Colombo. The topic is Dedicated Breast Clinic, a new responsibility for the General Surgeon in Sri Lanka.
Good morning. Dedicated Breast Clinic, a new responsibility for the General Surgeons in Sri Lanka, is the topic that has been given for the discussion today. I would like to first take this opportunity to thank the College of Surgeons of Sri Lanka for bringing up this timely topic for discussion. A general surgeon, or the field of general surgery, is a discipline that requires thorough knowledge of and responsibility of the preoperative, operative and postoperative management of patients with broad spectrum of diseases. General surgeon should be competent in diagnosis as well as treatment and management of wide variety of conditions. The American Board of Surgery demonstrate or highlight the requirement of a certified general surgeon and states that a surgeon should demonstrate broad knowledge and experience in conditions affecting the alimentary tract, abdomen and its contents, breast, skin and soft tissue, endocrine system. I am very proud to say that the Sri Lankan general surgeons are very keen and skilled in most of these areas and have a great interest in learning about new techniques, especially with regard to gastrointestinal tract, endocrine system, etc. However, we don't see the same interest with regard to breast surgery and to learn different oncoplastic techniques. And I believe it is a responsibility and not just a requirement of a general surgeon to be practicing update management in breast disease. So, a dedicated breast clinic, is it a new responsibility for the general surgeon in Sri Lanka? I think breast care has always been a responsibility of the general surgeon. And do we need to implement a dedicated breast clinic to provide an optimum service? Let's discuss and see. The concept of breast care clinic emerged with the introduction of special interest in general surgery in 2010 by the Postgraduate Institute of Medicine. And one integral step in this process was the introduction of a breast care clinic. We, at the National Hospital, took the initial step in establishing breast care clinic. And of recent, the Ministry of Health, after identifying the value of the dedicated clinic, has released a circular requesting all district and provincial hospitals to commence breast care clinics. I think the first step in establishing a clinic is to identify and form a team with a common interest. This includes the surgical team and other paramedical staff. Even the support of the radiologist, pathologist, oncologist is an integral component. Identify the common vision in your clinic so all members will work to achieve that goal. The vision in our clinic is to offer a comprehensive and personalized care service covering all aspects from diagnosis and treatment to aftercare and support services to both females and males with all breast-related problems. Then explore on the more feasible and stable options for establishing a clinic. Why not incorporate the breast care clinic to the general surgical clinic? A small area in your own clinic is good starting point. Formulate a separate clinic register book for the clinic. It is always good to appoint a separate medical officer to clerk the patients. This will ensure the proper continuity. Make sure all first visit patients are seen by the consultant and given a plan according to current guidelines. And it's very important to invite the health education nurse to participate in the clinic. You should also be able to provide a more specialized service that you could not achieve from a general surgical clinic. Having comprehensive assessment form with separate clinic book is important. Maintain the data and audit your work. Have a fast track system for malignancies. Especially have a fast track system in managing clinically suspicious or high risk patients for malignancy. I'm proud to say that in our clinic, we complete the surgical management within 2 weeks of the first clinic visit to all cancer patients. We have been able to achieve this with setting up of the breast care clinic. Continuing in specialized care, make sure to manage benign and malignant breast disease according to standard guidelines and have a proper follow-up. Start a multidisciplinary team meeting, update your team, encourage evidence-based practice, and make sure your clinic is compassionate and friendly and very comfortable, approachable environment to staff and the patients. This picture shows our health education nurse talking to patients at the clinic. Actually, you can see even males are listening. Update your knowledge on breast surgery and offer surgical care to your patients, ranging from simple lumpectomy to breast reconstruction to breast reduction surgery, etc. Maybe later, once you have your breast clinic functioning, consider getting down some additional equipment, instruments that the patients may benefit from, such as gamma probe for sentinel lymph node biopsy, especially if you do have isotope facilities. Today, our clinic in National Hospital of Sri Lanka is a one-stop clinic to all cancer patients. We provide imaging and biopsy on the same day with the support of the pathology and radiology team. So I think this is what you should also aim at. I just wanted to show the steady rise in patients attending our breast care clinic. And this still a small area in my general surgical clinic. So when I started the breast care clinic, I had to question myself. Have we identified the importance of breast disease, benign and malignant? Do we have a fast track system and proper follow-up clinic for malignant breast cancer patients? Are we maintaining data, records, and conducting audits? Do I have or should participate in a hospital or regional multidisciplinary team meeting? Do I have to update my knowledge? So, let's look at the impact of establishing breast care clinic. Improved the patient care and better and expedited treatment for cancer patients. We identified hidden problem in the society with females reluctant to discuss due to sensitivity of the issue. Macromastia, and started offering therapeutic reduction surgery, better management of complex breast disease with MDT input, continuous education of the staff and patients, and as for me, this became a very important component in continuous professional development of my career. Let's show you a few pictures of our patients. This patient had simple wide local excision, and she ended up with a normal breast with a tiny scar. Here, the upper outer quadrant tumor with a wide local excision and mobilizing the lateral base reconstruction. See this young patient with the after wide local excisions, upper outer quadrant with the LICAP reconstruction, she ended up with no scars. This is one of the key things what I told you is a breast cancer, not only the breast cancer and the macromastia with the therapeutic mammoplasty. You can see the reduction and they suffer silently without telling or without discussing this problem in the society. Tissue expander based reconstruction. You can see the tissue expander inserted somebody who had mastectomy earlier. Now here, this is the implant based reconstruction. Hardly any scar because the intra-mammary incision. Mastectomy with the other reconstruction, the LD reconstruction. Sometimes you might see this type of patient. This patient had wide local excision, margins were positive, end up with a deformed breast. And usually general surgeons always offer it. They see this type of patients for mastectomy. They came to us. What we did was we excised the margins and mobilized laterally, and she ended up with the normal breast. So, a dedicated breast clinic, is it a new responsibility for the general surgeon in Sri Lanka? My sincere opinion is that breast care clinic is the way forward in harmonization of breast care throughout Sri Lanka. Thank you.
Thank you very much, Dr. Ajit De Silva, for this very stimulatory lecture. I know you are one of the key surgeons in this country whose motto is to standardize the breast care in the country. And thank you very much again, and I think a general surgeon would get the message across. We'll move to the next talk. So next speaker is Dr. Pandula Hettiarachchi, who is a consultant radiologist in National Hospital, Colombo. He's going to talk about tips and tricks of imaging of breast, an essential commodity for breast surgeons. Over to you, Pandula.
Good morning. My name is Pandula Hettiarachchi, consultant radiologist, National Hospital of Sri Lanka. My sincere thanks to College of Surgeons giving me this opportunity. I need your help. Okay, sir. How to move it? Yeah. So we perform mammogram for the ladies with breast symptoms above 35 years of age. Below 35, we do ultrasound scan. In screening program, we do from about 40 to 70 years. So we do 2 views of each breast, called craniocaudal and medial lateral oblique. We use maximum possible compression to reduce the overlapping of tissues and spread out the tissues equally throughout the breast to easily identify a lesion. So when we are viewing a mammogram, we have to hang them or view them side by side, each side, right and left of each view, like this. So initial assessment is done according to the ACR guidelines, American College of Radiologists guidelines. There are 4 types of breast composition: according to the volume of fibroglandular tissue, entirely fatty scattered glandular tissue, heterogeneously dense fibroglandular tissue, and extremely dense fibroglandular tissue. The importance here is in a screening program, people with entirely fatty and scattered glandular tissue, if the mammogram is normal, you can send them back without doing further imaging. But with heterogeneously dense and extremely dense glandular tissue, there can be hidden lesions. So we have to combine the ultrasound scan as well to exclude a lesion. So we assess the imaging findings according to the American College of Radiology's Birads grading, breast imaging and reporting data system. So there are mainly six categories, 0 to 6. Fourth category is divided into three subcategories as A, B, C. So while you categorizing this, there's a management and likelihood of malignancy automatically comes. Birads 0 is incomplete study that needs further imaging modality or further workup studies. So management is recall the patient for further imaging. Likelihood of malignancy not applicable. Birads 1 is negative, that means or normal. Management is routine screening. Likelihood of malignancy is 0. Birads 2 is benign finding. Again, routine screening is management and 0 likelihood of cancer 0. Birads 3 is probably benign. Management is short interval follow-up in 6 months and continuous surveillance if there is no change. Likelihood of malignancy only 0 to 2%. Birads 4, there are 3 subcategories. 4A is low suspicious, 4B is moderately suspicious, 4C is highly suspicious. All 3 we need tissue diagnosis. So likelihood of malignancy goes up like 2 to 10%, 10 to 50%, 50 to 90%. Birads 5 is highly suggestive of malignancy. Again, you need tissue diagnosis. Possibility of malignancy is more than 95%. Birads 6 is biopsy proven malignancy. So how to assess a lesion according to the Birads? So basically there are 3 types: oval or elliptical shape, round or spherical shape, or whatever not oval or not rounded is irregular shape. That is suspicious for malignancy. This is how you see an oval shaped lesion. First one, A is oval shaped lesion, B is round lesion, C is irregular shaped lesion. So when you see a lesion, you have to assess the margin of the lesion according to the Birads again. There are 5 types: a circumscribed or sharply demarcated margin. Obscured margin is when more than 20% or 25% of the lesion is covered by the fibroglandular tissue. Microlobulated margin, where there are short circle undulations around the lesion. And indistinct margin, that means the inherited property of the lesion, margin of the lesion is not clear. And speculated or radiating lines. So the probability of suspicious goes up from circumscribed to speculated margin. So these are the types of lesions mammographically. B, the first one, B is circumscribed margin. Second one is obscured margin. Third one, again mentioned as A, is microlobulated margin. The top one over there is microlobulated margin. And the below one is indistinct margin, and the last one is speculated margin. So you are assessing the density of the lesion as well. There are 3 types of densities: high dense, equal dense, or low dense. Density is assessed according to the it's an equal breast tissue. You compare the equal density of the equal breast tissue of a similar area. So high dense lesions, we assess the lesion density like this in mammogram: high dense, equal dense, low dense, and fat containing lesions. The last one is fat containing lesion. Like that, we assess the density of the lesion in mammogram. So assessment of calcification is very important area to assess the calcification in mammogram according to the Birads. There are mainly 2 types: typically benign calcifications and suspicious calcification. There are a variety of benign calcification: skin calcification, vascular calcification, popcorn-like calcification, large rod-like calcification, round calcification, rim-like calcification, dystrophic calcification, milk calcium, and suture calcium. There's a large list of benign calcification to differentiate from malignancies. So these are the skin calcification. First picture is the skin calcification. You can see the calcification at the edge of the breast. Then you confirm that it's a skin calcification. Second picture is the vascular calcification. Third picture at the end is popcorn calcification, typically benign. And the bottom one is the rim calcification. So this is how you see the rod-like calcification in the first image. They form either within the duct or periductal, and they take the pattern of the ductal origin, and they are very dense and rod-like with sharp margins. They are benign. And the top one is, the below one is the round calcification. They occur within the normal acini. They take the shape of the acini with the sharp margin, round, dense, punctate calcification. And the third one is the milk calcium. Milk calcium occur in the dilated acini, and they change the shape in different positions. In CC view, they get the smudge appearance, but when you do lateral or medial lateral oblique view, it change the appearance to become teacup. So this, if you demonstrate the teacup, it is definitely benign. So the top one is a suture calcification, again benign, and following surgery, suture can be calcified. And the other one is the rim calcification over there. And the third one, bottom third one is dystrophic calcification, where there's a marker for the scar. So suspicious calcification. So those type of the benign calcification, suspicious calcifications are 4 main categories. Amorphous calcification. Top corner is amorphous calcification, where there is no margin for the calcification. And coarse heterogeneous calcification, they are coarse, but some kind of heterogeneity is there. And fine pleomorphic calcification, linear calcification, fine linear and linear branching calcifications. So according to this morphology, the probability of malignancy is going up. Amorphous calcification, 21% of suspicious. Coarse heterogeneous, 13% suspicious. Fine pleomorphic calcifications are 29% suspicious. Fine linear and fine linear branching calcifications are 70% suspicious. This is how you see the first one, how you see the amorphous calcification. That bottom coarse calcification also there, but above ones are amorphous calcification without any margin, smudge-like calcification. The B is the pleomorphic calcification, and the bottom one is the coarse heterogeneous calcification. C is the combined pattern, where there are pleomorphic, amorphous, and fine linear calcification all together. And this is how you see the fine linear calcification. These are very suspicious. Fine linear calcification. All 3 images shows fine linear calcification. Sometimes you can see branching as well. Some difficult to diagnose without any keen eye. And that is the morphology of calcification. We have to consider the arrangement of calcification as well. So there are mainly about 4 to 5 types of arrangement. If the calcifications are diffusely scattered, it's considered as benign without any suspicious. Or if the calcifications are in regional arrangement, it is 26% of suspicious. And if the calcifications are in a group or cluster, about 31% of suspicious. And if the calcification arrangement is in linear, I mean pleomorphic calcifications are arranged in linear, it is about 60% in suspicious. If the suspicious calcifications are suspicious morphological calcifications are in segmental arrangement, it is about 62% suspicious. This is how you see the arrangement. This is diffusely scattered. Calcifications can be seen everywhere without any particular pattern. And regional arrangement, calcifications are in a in one, it's a larger than a cluster but a smaller than a segmental arrangement, so it's in a regional distribution, and bottom one is the cluster. This is how you get the linear arrangement. The microcalcification comes in a linear arrangement within the ducts. So this both B numbers are linear calcifications. You can see multiple linear arrangements, and bottom one is the segmental arrangement. This is very suspicious. Calcifications are involving one whole lobe, so that is segmental arrangement. So we have to look for the associated findings. Once you see a suspicious lesion, look for the associated finding. The first one you get is skin indentation with the suspicious lesion. Beyond that, this skin indentation is the associated finding of a malignancy, and nipple retraction is one of the other. Nipple retraction is other associated finding, and skin thickening. Third one is skin thickening and trabecular thickening due to skin involvement or either edema, and the calcification going away from the lesion. Or within the lesion also you can see calcification, but when the calcifications are going up, it's an associated finding. That means Dcis is extending away from the lesion. And the associated axillary lymph nodes. The third one, you will see the arrowhead is the lesion is down, but there's an enlarged lymph node at the axilla. So those 5 stuff are the associated findings to look for when there's a suspicious lesion. So when we are not clear with the lesion, we have to do workup views. One of the important workup view is the spot compression view. The first one you see is the subtle lesion, subtle stromal distortion, which is rounded, which is not clear. But the second view is the spot compression view. You can clearly see the malignancy there. And the third picture is just a stromal distortion that you see in the mammogram, but you do the compression and include in the tomosynthesis, its malignancy is demonstrated. Other workup view is compression plus magnification. That is to clarify the malignancies more clearly with their proper characteristics. So this first A is the normal view. Once you do the compression and magnification, the margins become more clearer. And bottom one is just the lesion we saw, but when you do the magnification, we start seeing calcification within the lesion. So there's a new technique, or fairly new technique called tomosynthesis, where in addition to the breast compression, they take slices of the breast, and then it is more clearer than the just compression only. So in tomosynthesis, margins become more clearer. The first top one is the normal 2D mammogram, but when we did the tomosynthesis, margin become more clear. Even in the malignancies, speculated margins become more clear in tomosynthesis. So we do the ultrasound to see some additional features more than the mammogram. So what are they? So you can see the long axis of the lesion, in which way if the lesion, long axis of the lesion is parallel, it is more benign. If it is non-parallel, it is suspicious. At the same time, you can see the posterior feature of the lesion, which is not a property of a mammogram. Only ultrasound scan only we can see the posterior features. There are 4 types of posterior features. There's no posterior feature is the first one. That means there's no proper transmission of the ultrasound through the lesion. And enhancement you can get, posterior enhancement you can get at the cyst, where there's a fluid, where the ultrasound transmit more faster than the other soft tissues. So posterior more whiter than the other areas. And with a lesion with more fibrosis, you get posterior shadowing. Most of the fibrotic malignancies, you get posterior shadowing. Sometimes you get combined pattern, shadowing and the enhancement. Also, you can see the composition of the lesion in ultrasound more clearer than in the mammogram. Cysts are more black. That means there's fluid within the cyst. Those are black. That you can't see that in the mammogram. In fat-containing lesions are white, hyperechoic, and complex cysts are with shows some solid and cystic areas together, which is again can see only in ultrasound. And complicated cyst is different from the complex cyst, where previously benign cyst become hemorrhagic. You can see uniformly thick wall and internal particles. That means complicated cyst. You can directly aspirate complicated cyst, and you will be able to see the calcification also in the ultrasound. Here, first one is the fibrocystic disease with some cyst. The calcification you can see as white dots which are lying on the wall. So most of the time they become benign. And calcifications of the cancer, which is extending from lesion to anterior, that means Dcis, that also you can see in ultrasound, where the calcifications are within the ducts. So at the same time, you can see the skin thickened skin edema on ultrasound as white thickening of the skin, sometimes with lattice-like low echogenic areas. So how to identify a lymph node in mammogram? Normal lymph nodes are thin lines, thin white lines with black fatty hilum. When the lymph node enlarge, it becomes more denser with the loss of fatty hilum. And you will be able to see bilateral enlarged lymph nodes in lymphoma patients when you take a mammogram. If you take bilateral symmetrical lesions in mammogram, it's almost always the secondary deposit of lymphoma, leukemia, or any other malignancy. And an interesting lesion is called radial scar, where there's the mammographic lesion looks malignant. You have to give Birads 5, but when you do ultrasound, there's no particular lesion as such, only stromal, only heterogeneous glandular tissue and some cystic areas. When you do biopsy, it shows only benign finding with proliferative glandular glands. So there are two types of cysts that you miss in ultrasound, the particular characteristic, because cyst with normal clear fluid or whatever watery fluid, in mammography it is denser, but oil cyst, mammography it's low dense because it contains oil. X-ray doesn't give any dense lesion. This is the only drawback of the ultrasound in comparing the mammogram. The other important thing is the hematoma. Hematomas looks like large lesions, but if you demonstrate fat-containing areas within the lesion, is almost always hematomas. Sometimes they are fat lesions, and with central dense areas. So we use color Doppler to assess the lesion, whether it's a solid or fluid-containing lesion. If it's a solid lesion, you can see the color going into the lesion. If it is an abscess, the color is only around the lesion without much color within the lesion. So you can differentiate abscess and the lesion from color Doppler. We use elastography to differentiate malignancy and a benign lesion by assessing the stiffness of a lesion. They get a color box. The red area is more stiff area. The stiff areas of this malignant lesion, you get top one red area is a stiff area that you are suggesting of malignancy. And for fibroadenoma, the below one is a fibroadenoma. You don't get much red area, only all blue area, that means soft lesion. So we perform MRI to assess the lesion as a problem solving tool when the all mammogram and ultrasound are not conclusive. We go ahead and do the MRI as well. MRI, we use contrast as well and assessing a kinetic curve, where the enhancing curve, there are three types. So this is the benign type. First one is the benign type with progressive enhancement, and the second one is with plateau with rapid enhancement, but after that it goes as a plateau. Then again it's intermediate type of curve, and third curve over there is the suspicious curve, type 3 curve, where the rapid wash in and wash out, then it is suspicious curve. And sometimes MRI you see at the last one with non-mass enhancement, where there is no mass in the mammogram or ultrasound, but when you do MRI with contrast, you start seeing enhancing areas. So almost always the Dcis or some kind of inflammation, you have to apply the curve and see. So we perform many interventional procedures. First one is the core biopsies using
You'll have to probably hurry up.
Yeah. Oh, yeah, sure. Only one slide.
Yeah.
So we use core biopsy with using 14 gauge cutting needle, you can directly see the lesion and puncture. And this is what you call stereotactic biopsy, where the patient is fixed into the machine with the needle on top, and we do two action comes from the suction and cutting. And so vacuum biopsy is very promising for calcification. You do the sample radiograph and you can demonstrate the calcification there. And we use hook wire localization, where there's a hook wire and ultrasonic, where the non-palpable lesions, ultrasonic guided and mammographic guided, we use hook wire, and then later surgeon can take it out. So finally, we do pre-chemotherapy clipping for malignancies. We use a locally made method to use the Liga clips, bending that into two, and with using a artery forceps, and push that into malignancy using introduce a needle. So finally, we do microwave ablation for lesion, benign lesions using microwave antenna. It's a scarless therapeutic lesion, the therapeutic procedure. We can directly insert the needle into the benign lesion and burn. Once it totally burn, it becomes a totally white lesion. And this is very promising. The lesion is going off in about 6 months to 1 year time without any scar. Okay, thank you.
Thank you very much, Pandula. Our next speaker is Mr. Mike McCurdy. He is the president-elect of the Royal College of Surgeons of Royal College of Physicians and Surgeons of Glasgow. I think he will join us with the recorded lecture.
Good morning, everyone. And can I firstly say what a delight it is to be here with colleagues in Sri Lanka, virtually in this presentation, but on the very memorable occasion of your Golden Jubilee of 50 years of the College of Surgeons in Sri Lanka. My name is Mike McCurdy. I'm an oncoplastic breast surgeon working in the Glasgow area, and I am president-elect of the Royal College of Physicians and Surgeons of Glasgow, with whom I'm delighted to say you now have a very strong connection, which has been a great pleasure for our college to have the partnership that we have with you as colleagues in the College of Surgeons in Sri Lanka. I've also been the Scottish clinical lead for breast cancer services for the past 2 years. When I took up that role, I didn't see the pandemic coming. I suppose none of us did, but it has given me a chance to look at how we've delivered services through the past 20 months or so in the very challenging time of the COVID pandemic. Scotland, as you will probably know, is a very small part of the UK, stuck geographically on the top, population of 5.4 million people. We have 14 territorial health boards that organise healthcare through the National Health Service. And we deal with just under 5,000 new cases of breast cancer annually in Scotland. 30% of those are found through the National Breast Screening Programme. 70% come to see us with breast symptoms, and we find the cancers in amongst those who present at what we call one-stop clinics. And we have 18 of these in Scotland. And many of you will be familiar with the concept, where we have breast surgeons, specialist breast radiologists, pathologists, breast care nurses, all working in one place at one time to make good and reliable and rapid diagnoses of breast problems. So our UK national lockdown started on the 23rd of March 2020, and we had to pretty quickly adapt what we were doing. On the left of this slide is Buchanan Street, the main thoroughfare in the middle of Glasgow for shopping, and in a normal Saturday it will be thronged and packed. On the right of the slide is what Buchanan Street looked down as we began that lockdown process, that there were very few people around. Most businesses and shops boarded up and closed, and many of them have still not, 20 months later, been able to reopen. You'll be familiar with that through your experience here in Sri Lanka. The last experience that we'd had with the pandemic in the UK was 1918, 1920, with the influenza pandemic. It's estimated that somewhere around 20 to 50 million people died worldwide. The figure may be double that. And it was named in Britain Spanish flu, which we now know, having been through this more recently, is an experience that we have of othering things that are not to our liking. And we're familiar in the UK with Indian variants and so on. We want to say it's somebody else's fault. And including in that, in the UK at that time, was to blame all of this on the Germans because the drug company Bayer had just invented aspirin. And that was really the only treatment there was in that pandemic just over 100 years ago. Interestingly, the literature from that time shows us that people did use physical distancing and space between people, face masks, particularly in East Asia, and hand washing all became part of the fight against that influenza pandemic. And interestingly also, from our point of view, the creation of emergency hospital beds and large auxiliary hospitals were opened up and down the UK. So when the pandemic hit us, we did something similar. And this is a picture of the NHS Louisa Jordan, which was built on the banks of the Clyde. Those of you who have been following the COP26 conference earlier this month, and when world leaders gathered to discuss climate change, know that it happened in exactly the same place, in what was a former shipyard and docking station on the River Clyde. We created a hospital with 300 beds with capacity to go up to 1,000 beds. And that hospital, pretty remarkably, opened on the 30th of April, just after 5 weeks' work, which is very fast for the British building industry and the British NHS to achieve that scale of provision. However, the hospital never ever had a patient in it. We ended up using it for some outpatient visits, and then as the vaccination programme began in 2021, it found a role, and it closed only 11 months after it had opened. The Scottish response to COVID, particularly in the breast community, was to hold a lot of virtual meetings and to share experience and try and learn from what one another were doing and to agree some common protocols. We were all in the dark. We'd never done this before, and we needed to learn how to repurpose ourselves and breast services across the country. In the whole of Scotland, all outpatient departments were immediately closed at the time of national lockdown. The only operating was in emergency cases. And we've had some discussion as a college with colleagues in CSSL to look at how you were able to undertake your own prioritisation of work when the wave of COVID came through Sri Lanka earlier this year. We were also very fortunate in the UK and Ireland to have an active association of breast surgeons, and they produced guidance actually before national lockdown about how breast services should conduct themselves. We looked first of all at referral triage. In the UK, it is common for us to see 100 women in our clinics in order to find 3 breast cancers. So 97% of those who come to see us do not have any cancer problem. And we had to start to weed out from the usual referral and find the people who are most likely to have a cancer, because everybody else should rightly and properly have been staying at home at that time. We also had to agree surgical protocols, and I'll share those with you in a moment. We started to avoid the use of systemic chemotherapy because of the concern that an immunocompromised patient, if they picked up COVID, would very likely die. And we quickly modified our radiotherapy treatments. And we used a lot more endocrine treatment. People who did have estrogen receptor positive tumours received that on a neoadjuvant basis. And those people who couldn't come to see us and who were very likely to have breast cancers and who were elderly and frail were simply started on empirical endocrine therapy without actually coming anywhere near a hospital. Because our hospitals at that time were the most dangerous places to be in the country, because that's where the COVID patients were. So we got used to webinars, and I'm sharing this as a recorded meeting from my home and recorded presentation from my home in Glasgow. We've all got used to these over the years. There's a picture of me in the middle. When the meeting starts, we'll let people know you're waiting. And we've all got used to this and working with screens. And that's perhaps been one of the positives from the pandemic, that we've learned much better how to use IT. We had every 6 weeks or so a meeting for all the breast teams in Scotland to come together. And at the very beginning of the pandemic, the UK community were able to have regular updates on practice around the country, particularly in the first few months, with evening webinars after the working day was over. So for referral triage, we went to our national accepted guidance pathway, which had been published in January 2019, and we agreed that we'd see urgent cases only and where cancer was likely. We had to ask people to check for COVID symptoms and to do temperature checks whenever he came to the hospital, because at that time we had no way of testing for COVID. And we didn't know who had or didn't have COVID, and everybody was, rightly and properly, a bit fearful of getting it, because we didn't know very much about treating it, and our outcomes at that time were very, very challenged. We asked people to attend alone and not bring family members with them. And we asked the people who were over the age of 70, and in the UK, that age group was asked to shield, that is, to remain all the time inside their own homes and to get neighbours and friends to do their shopping and not leave their homes at all. And so we asked those people to stay at home, and if they seemed likely to have a breast cancer, we started them, as I mentioned earlier, on empirical letrozole. If a breast cancer was diagnosed, we placed a clip in the middle of the tumour at ultrasound at the time of biopsy, so that we could go back and find those tumours, because we didn't know how long it was going to be until we were operating on people again. And with endocrine therapy, as you know, tumours will shrink and indeed disappear. We prioritised surgery, and our nationally agreed protocol was to operate on those people who were estrogen receptor negative, those who were HER2 positive. If they were ER positive and premenopausal, they came into our third category to go ahead with surgery. And for people in whom we thought the biopsy was likely to show a high-grade tumour, or who did have node-positive disease at diagnosis, and we usually assess the axilla by ultrasound and biopsy in the UK, then they were our fourth category to go ahead with surgery, but usually only after genomic testing, proving that they were at higher risk. Large areas of DCIS were our fifth group, and we simply said to those who had small screen detected areas of DCIS to stay at home, and we would get to them in due course. We stopped all oncoplastic surgery, and there was no immediate reconstruction. And the rationale for that is that oncoplastic surgery and immediate reconstruction obviously take much longer to conduct as surgical operations. Theatre time was extremely tight, even when we started operating again on cancer, which was about May, June time. And we did not want people to be coming backwards and forwards for multiple trips, for wound dressings and so on. And those of you who do oncoplastic surgery and breast reconstruction will know that these patients often need to come for dressing changes, and complications are unfortunately common. So all of that kind of surgery was paused. We did see this as an opportunity for research, because we're in a new situation. And the particular collaborative piece of research that we've conducted through the Association of Breast Surgery was to look at our MDT and the outcomes. And we agreed that we would record for all patients whether or not their treatment recommendation had been altered by COVID. In other words, our standard treatment had been changed by the pandemic, and that we would record that, and we emailed our MDT outcomes on a weekly basis to a central registry. As yet, there's no confirmed data from that, but we're hoping that that will be shared for the UK in January of 2022 at our national meeting for breast surgeons in the UK and Ireland. Just as the COVID pandemic hit us, the fast forward trial of radiotherapy after breast conserving surgery had been shared. It was published in May of 2020 in The Lancet with one of my colleagues here in Glasgow, Abdullah Al-Hassel, as a lead author. And that proved that there was no need for people to attend for the traditional 15 fractions of radiotherapy, which obviously means 15 visits out of their home to the radiotherapy centre, but instead that could be achieved with 5. And so we saw this as an opportunity to very quickly put into place the outcomes of that research collaborative and reduce radiotherapy visits. In a similar way, cancer follow-up, we'd agreed in the UK there was good evidence that that did not necessarily involve patients attending hospital for a follow-up visit. And so what we did at that point was we moved all follow-up visits to virtual, and these were held either as telephone or video consultations, and people would then only attend for the mammogram and not come to a clinic also. We paused the National Breast Screening Programme for a 6-month period in 2020, from March through to September. As many of you will know, the UK started a national breast screening programme over 30 years ago in 1990, and all women aged between 50 and 70 are invited to come on a 3-yearly basis and have a mammogram. It's a good program. It finds 30% of our cancers in the UK. But in order to find 7 cancers, as these numbers demonstrate, we have to invite 1,400 people to leave their home. Of that 1,400, 70% usually do, so 1,000 will attend. 40 of them are called back for a second visit, and we find 7 cancers. So that's a lot of visits out of people's homes at a time when we were supposed to be staying at home and only leaving our homes for essential shopping or for a short period of daily exercise. In addition to that, the cancers we find through this program are tiny, 50% of them less than 15 millimeters in diameter, and 20% of the disease is only in situ disease and there is no invasive component. So we thought it was safe as a breast community to pause that whole program for that 6-month period. Indeed, we know in 2020 that we're missing about 1,200 cancers in Scotland, but we also know that 1,000 of them at least are because of this pause in screening. And now that screening is working faster than usual, we will find them in the coming year or so. And we believe very strongly that nobody will be significantly disadvantaged by the way we've organised breast services in Scotland during the pandemic. Sentinel node biopsy was another difficult area for many units up and down the country because we usually use the double dye technique of blue and technetium. And the location of surgery is locked into the IRMA regulations that allow us to use isotope, and these are very strict in the UK. We had to repurpose our services and use hospitals that didn't traditionally or normally do breast cancer surgery, some of them in the private hospital, some of them are elective hubs for orthopedic surgery. And so we had to move house, as it were, in the middle of the pandemic and operate in other facilities. And so many units have moved to using alternative tracers, MagTrace and fluorescent dye. And that, in fact, as we've come out of the pandemic, has been really helpful because we've been able to stop using technetium. And indeed, our own unit, my own unit in Glasgow, is following that course now and leaving behind the using of technetium. As we restarted services in September 2020, after that first lockdown period, we had to repurpose our hospitals. You'll be familiar, I'm sure, here in Sri Lanka with these kind of signs. Keep apart, use physical distancing, wear masks, remember to wash your hands. But this, of course, had an impact on our capacity in the hospital because we couldn't have crowded waiting rooms as we were used to. We couldn't have crowded wards. We couldn't have case after case going through the operating theatre. We had to leave gaps, physical gaps, time gaps for changes of air in operating theatres and so on. And that's severely reduced capacity across our services. As we've come through this last winter and into 2021, we've been talking about restoring the health service or recovering the health service. And we've still had to do that with social distancing and so on, as I just mentioned. But one of our critical issues has been staffing. Anybody in a household here in the UK in whom another member is tested positive for COVID is asked not to come to work, not to spread that COVID further in the community. And that's meant that at any one time, we've had significant numbers of staff unable to come to work. We've also had to repurpose staff and send them to other areas of the hospital to look after COVID patients and our frail elderly patients who are not getting home or out to nursing homes as quickly as they previously did. We've also had to take into account staff well-being. We began to see across our hospitals these kind of posters going up about taking a moment before you go home, considering what happened to you today at work, being proud of what you did, consider 3 things that went well, and now go home to rest and recharge. Because staff mental health well-being has been a real challenge here, as I'm sure it has been for colleagues here in Sri Lanka. We're all having to live, I suppose, with a new normal. So where we've got to across the country is we do still have an outpatient backlog, not a significant one in breast cancer services, because we have been able, by using the methodology I shared with you, of being nimble, by sharing experience, by moving house in the middle of the pandemic, we have managed to keep our waiting times down to around 2 to 4 weeks across Scotland to come for a breast appointment. But our colleagues in other services have a very significant outpatient backlog. There's been a real issue about surgical capacity going forward. In my own hospital at the moment, we're only able to use 4 of 13 operating theatres. We have, it's estimated, about 5 million people across the UK currently on waiting lists. And we're now facing a situation where the NHS is coming in for criticism and not the clapping that we saw every Thursday evening at the beginning of this pandemic. So it's been a challenge, but I've enjoyed sharing our experience with you this morning, and I wish you well. Thank you very much for your attention.
Thank you very much, Mr. McCurdy, for your interesting talk and sharing your experience with us. In Sri Lanka, we haven't, changed much in the management of breast cancer during even pandemic, but we learned a lot from you because the pandemic is still around. So still the cases are popping up. So this is very informative lecture for the surgeons practicing breast care in our country. Thank you very much for joining us. And we got a couple of minutes. If the organizers are okay, we can, there's a couple of questions asked. Do we have time for a couple of questions? So one question from a virtual audience. Do we need to do both mammogram and ultrasound scan in young patients less than 35 years who is having biopsy proven breast cancer? I think it's for the radiologist Dr. Pandule Tiarachi. Yeah, the answer is yes. We have to do both mammogram and ultrasound scan in a patient less than 35 years who's having a biopsy proven breast cancer. So in the absence of any other question, I would like to conclude the symposium number 8. I would like to thank all the speakers, Dr. Ajit De Silva, Dr. Pandul Hettiarachchi, and Mr. Mike McCurdy joining us. So thank you very much. We'll move to the next. Thank you.